is it somehow hitting 2 of those or all 3 of those? Are we going to determine if the pathology is in the central nervous system or in the peripheral nervous system, primarily because, as one of my patients asked one time, actually it wasn't a patient, it was the wife, can't you just MRI his entire body? And the answer to that question is no. So you want to make sure that you're focused down in terms of what you're looking at. Does it require urgent or emergent intervention? And does everything correlate? Does what you find and what you're hearing on history equal what you're finding on clinical exam equal what you're finding on radiographic exam? Okay. There are some labs, and as we talk in CMS2, when we go specifically into the neuro module, there are some labs that you do with regards to neurological exams, but they're not that many. Really what we look more so is at radiographic imaging. So obviously we all know this, right? For those of you that this is a huge review and you totally like crushed anatomy and phys for neuro, I don't mind if you fall asleep, just don't snore. So when we talk about the neurological system, we have both the central and the peripheral. When we talk about the central nervous system, we're really just talking about the brain and the spinal cord. When we talk about the peripheral nervous system, we are talking about cranial nerves. Even though they are in the brain, they are considered part of the peripheral nervous system, as well as all of our peripheral nerves. Those are the ones that directly come off of the spinal cord, but also the ones that kind of start to move and shake around a little bit, right? As they move through the brachial plexus, they all kind of bifurcate and they rejoin and they join their partner next to them. So we end up having mixed nerves as we moved distally into the arms and into the legs. When we talk about neuroanatomy in terms of white matter or gray matter, very important in terms of especially for the brain, but also for the spinal cord, because we've got white matter and gray matter in both. When we talk about white matter, there we're talking about essentially myelin coated nerves, right? So think of basically nerves that are kind of wrapped up in bubble wrap. And when we talk about the white matter and we talk about the destruction of the myelin, whether it is occurring within the spinal cord or whether that's occurring within the brain, you're going to see those lesions in those specific areas. You aren't going to see them, for example, Guillain-Barré, for example, MS. You're really not going to see those lesions in the gray matter. So when you start to see everything kind of coalescing into the white matter, it points you towards your right diagnosis. Whereas when we have gray matter, we're basically having neuronal cell bodies, just kind of that aggregation of all those cell bodies. When we talk very briefly, we'll kind of go into more detail about this, but when we talk about the hemispheres of the brain, so we have the cerebral hemispheres, we have the basal ganglia, we have the diencephalon, which includes both the thalamus and the hypothalamus, remembering that the thalamus is that huge relay station for all sensory input. Basically, everything from your body is coming up and going through the thalamus before it gets to the sensory cortex within the brain. And the hypothalamus is kind of like in control of the pituitary. So it's like the motherboard to the motherboard, okay? When we talk about the brainstem and the cerebellum, remember when we talked about that case last week in the matter of baby K? So she had basically a brainstem. She had no cerebellum, she had no cerebral hemispheres, no thalamus, nothing above that, okay? So we talk about the diencephalon, just kind of put this up there in terms of thalamus. Thalamus is located just adjacent to, and we'll show more pictures of it later, the third ventricle. So the ventricular system in the brain includes a lateral third and fourth ventricle. That's where your cerebral spinal fluid is produced and where it circulates. It's kind of like the water in the jar, so that your brain isn't just kind of hanging out. It at least is floating and suspended in space. And the hypothalamus, again, is that motherboard to the motherboard, right? So it controls everything that the pituitary is driven to do. We talk about the basal ganglia. So the basal ganglia is one of those deep nuclear structures. When we talk about basal ganglia, there's a slide later. Basically includes the putnam, plus or minus on the substantia nigra. It just depends on which article you look at. Sometimes they fight over where it should be included. But really, when we talk about the basal ganglia, we're looking at all deep nuclear structures. So basal ganglia is going to help coordinate those fine motor movements. So key diagnosis to kind of think of right away is Parkinson's disease. Okay. Whenever we talk about treatment of that in terms of surgical treatment for Parkinson's disease and placement of like a deep brain stimulator, we're looking at the structures within the basal ganglia, whether it be the putnam, whether it be the globus pallidus, whether it be the substantia nigra, to try to place that lead as effectively as possible to help coordinate their motion better. Okay. So when we talk about the lobes of the brain, and just generally speaking, we have the frontal lobe, which everybody kind of always shortchanges the frontal lobe. The frontal lobe is actually much bigger than we think it is. We have the parietal lobe, the temporal lobe, and the occipital lobe. And they're responsible essentially for motor function, sensory function, basically all higher intellectual function. Your math skills, your hearing skills, your language skills. Everything that it took to kind of get you into PA school is taken care of within those hemispheres. When we talk about consciousness, so hopefully everybody's awake today, and hopefully you've all had your beverage of choice to be awake this morning. But really what we're looking at is the reticular activating system or reticular activating formation. So basically it's all of that input that we're getting for both wakefulness as well as like arousal. So it kind of helps to keep you awake, helps to keep you alert. So it's functioning all the time. And it really actually passes directly through the thalamus as well, because again, that's where we're getting all of our sensory input before it moves on to the sensory cortex within the brain. Oversimplification, when we talk about the frontal lobe really has the motor strip, which we have a good picture of where that motor strip lies. But again, the frontal lobe is always shortchanged in terms of actual size. It's a pretty large lobe of the brain. Always remember that, I always like to refer to my patients as being frontal lobish, right? Because that's where a lot of their personality is harbored. When you have patients, for example, after traumas, car accidents, and they get brain injuries or we get concussions, and everybody's acting kind of goofy, typically what they've injured is their frontal lobe for a couple of reasons. The frontal lobe, obviously, it's in the front, okay, and it's large, but it also, remember your anatomy in terms of your skull base at that level. So your skull base at that level with regards to the ethmoid, the cribriform plate, the underside of the skull in that area, think of it just like a cheese grater, because that's exactly how sharp it is, okay? I've cut many a glove on the bones right in front of the frontal lobe. And basically, that's what your brain will just slide right over when you have a head injury. So when they talk about the frontal lobe and they talk about people being a little goofy afterwards, they're not kidding. They have a structural reason for that. Then we move on and we talk about the temporal lobe. So the temporal lobe really is in charge of auditory. Obviously, it's right out by our ears, but really plays a big role in terms of our speech as well. Not necessarily both reception of speech, because it is how we hear, but also transmitting that what we hear and what we need to say and what actually comes out of our mouth. Okay. When we talk about the occipital lobe, so really that is our visual cortex. Even though our eyeballs are in the front of our head, remember that your eyeballs are simply an extension of your brain. As you're developing in utero, they are basically pushed forward. And what you're seeing, like I'm seeing you guys, is being reflected in my occipital lobe, in my visual cortex, and that's how I kind of know most of your all's names. I'm getting there, okay? But it's how you look and you know that a tree is a tree. How you look and know that a stoplight is a stoplight, because you've learned that over time and that's been trained and thought process in your visual cortex. When we talk about the parietal lobe, primarily with the parietal lobe, we talk about somatosensory. So again, as we're relaying everything up through the thalamus, where it is basically landing is on the sensory cortex, on that somatosensory. So it is then transmitting to the motor cortex, which is just in front of it, in that frontal lobe, basically puts you into action. Okay. Talk about the thalamus, again, that primary sensory impulse, and it relays everything up to the cerebral cortex. Basically, everything that's occurring in the rest of your body has to pass through the thalamus to get to the somatosensory cortex. It just has to ascend before it can essentially descend into actual motor function. And the hypothalamus, again, helps to maintain homeostasis, temperature, heart rate, blood pressure, but it does a whole lot of other stuff too in terms of regulating a lot of our hormones because it's in direct relay with the pituitary gland, okay? So when we talk about the various cortices, when we look here, I got a pointer today. So you have the primary motor cortices and the precentral gyrus. So basically all of this here is the frontal lobe, okay? So it is quite large. When we talk about the primary sensory cortice, that's just posterior to it, and that starts with our parietal lobe. Our visual cortex is way in the back in our occipital lobe, and then we have essentially our auditory complex, which is right here in the temporal lobe. So that's just kind of gets you a little bit closer in terms of how everything is integrated. Our motor area, so when we talk about the basal ganglia, so again, when we talk about the basal ganglia and what all it entails. It is quite a large structure. So it is involved in the gray matter. So it bridges the cortices the thalamus as well as other areas. Basically, it turns what you want to do into your expression of movement. So again, I always think of Parkinson's disease. Those patients, they know that they want to walk, they know that they want to pick up a plate, and they know they want to do it with fluid motion, and yet it doesn't happen in fluid motion. Okay, they have that shuffling gait, they have that shake, that tremor. So their body knows what to do, they're just not able to transmit it into appropriate motion. We talk about the cerebellum. So the cerebellum is directly involved with all of our coordination. It kind of helps us know where we are in space. It helps us basically to remain upright. When we talk about balance issues, for patients, we talk about three main contributors to our balance: our cerebellum, our visual cortex, and our proprioception within our joints. Okay, so you can lose one and be fine. But typically, if you lose the cerebellum and what you have maintained as vision and proprioception of your joints, you're still going to have some balance issues. Okay, cerebellum kind of takes the cake in terms of being the most important with regards to balance and coordination. So when we look at the primary motor cortices, and again, remember, we're looking in that most posterior aspect of the frontal lobe. The way to always remember it, and I don't know if you were taught it this way, is HAL. Okay, head, arm, and leg. Makes it very easy. So when we move to the medial aspect, okay, and this is essentially the medial aspect of your hemisphere. So this is always leg up toward the center. And as we move lateral, arm is out toward the lateral aspect, and head is way to the lateral aspect of the motor cortice. Okay. The good thing to remember about that, and we'll talk a little bit today about blood flow to the brain, is the reason why the majority of strokes occur and they affect the face and the arm is directly because of what artery supplies the HA of HAL, versus people who have leg weakness which is supplied by a different artery that only really supplies the L. Okay, and the majority of strokes that happen in the world. In the world. Okay, 85% of all strokes that occur take out an artery called the middle cerebral artery. And it takes out H and it takes out A. So that's why most people that you see have facial weakness and have arm weakness. It's the biggest artery that contributes to stroke. When we move on to the somatosensory or the sensory cortex, basically kind of follows about the same guideline with a few exceptions, you know? Yeah, your genitalia are down in the center somewhere. They'll be fine, right? But see, up here we still have leg. Ballpark it, we still have arm. Okay, yeah, you can we got some other stuff, intra-abdominal, but really you do have head, okay? So you can still think of HAL when you think of the primary sensory cortex as well. They basically mirror each other. And it makes it easy because, you know, one's sitting right behind the other, so they might as well talk to each other and be nice and kind. This picture kind of creeps me out. I gotta be honest. All right, but anyways, it's just another way to look at both the motor cortice, which you see here, being a little bit anterior, and the sensory cortex being essentially right behind it, and they do essentially align with each other. Here's your little foot, here's your little foot. This hand looks a little bit bigger, might just be the picture I put up. This face looks funny. But basically, how? Okay, head, arm, and leg. So when we talk about the primary motor pathways, how am I doing that time? Am I talking too fast? No? Everybody awake? Yeah. Kind of? Okay. All right. I got some Diet Mountain Dew up here just in case anybody's not. All right. So when we talk about the principal motor pathways, you basically have the pyramidal system and the extrapyramidal system. So when we talk about the pyramidal system, we talk about the corticospinal tract and the corticobulbar tract. And the corticobulbar tracts are easy to remember because they're basically just the cranial nerves. Okay? And corticospinal tract is everything else. Okay? When we talk about the extrapyramidal system, so again, there we're talking about the basal ganglia. So again, kind of always think back to those motor disorders, movement disorders. Okay, and that's kind of where you're going to end up having some degradation that results in the motor disorder, or the movement disorder, okay, is in the basal ganglia. And you have the cerebellar system. So the cerebellar system is your understanding of where you are in space, your position sense, kind of helps keep you balanced. that kind of stuff. Just so you know, so here, just to kind of sidetrack, as we move south, as we move inferior, remember always that the corticospinal tracts, the majority of them cross, ballpark it 80 to 85% cross, okay? Not all of them do though. But again, that's always why the right side of our brain controls the left side of our body, and the left side of our brain pretty much controls the right side of our body, because the majority of those tracts actually cross over. Again, when we talk about the basal ganglia, so we've got globus pallidus in there, substantia nigra, subthalamic nuclei, the putnam, basically all of that is the basal ganglia, okay? Plus or minus. Again, some people kind of like to argue over the substantia nigra. They're just like, why argue? But that is one of the lead placements that they do for Parkinson's disease. So that's why those people in that camp argue that it's part of the basal ganglia, okay, in terms of motor disorder. When we talk, and then this is essentially your thalamus. So essentially here's your lateral ventricle. Basically, this is a coronal section. So I know that you guys have had neuroimaging, right? So I always think of the suture lines in the skull, and that's how I kind of always used to remember radiographic imaging, right? So essentially your sagittal suture, your sagittal sinus, you had your coronal suture, and the other one was axial, right? Makes it easy. So essentially we have a coronal image here. So we have the lateral nuclei, the lateral ventricles, which is where your part of where your CSF is produced. And then it's going to matriculate down through the third ventricle. So your thalamus essentially sit on either side of the third ventricle. So when you talk about deep nuclear strokes, okay, and I know I'm kind of jumping ahead, but it always helps for me to think about actually pathology, right? That's what you guys actually want to learn about anyway. So I hope so, right? Okay. All right. So when we talk about deep nuclear strokes, typically areas that they're talking about are basal ganglia. Okay. So my motor function is not going to be so great. That doesn't sound too good. Or the thalamus. Okay. So when they talk about, because the vessels that go there are finer than your hair. So when you take a hit there, when you actually have a hypertensive or hemorrhagic stroke there, done. Nothing else is feeding it. So you either have an area that's supposed to help relay my movement into fluid movement, basal ganglia, or that's supposed to be the relay station for all my sensory input in my thalamus and relay it up to my somatosensory cortex. So my motion's probably not going to be so good because my input, for lack of a better word, sucks, right? So if you're not getting appropriate input into your thalamus and it can't relay it north, your motor strip might be fantastic, but it's still not going to have the appropriate output. Okay. When we talk about the cerebellum, so the cerebellum is divided into multiple sections, but kind of think of this lovely little area here, the vermis. So the vermis is kind of like the corpus callosum, right? So the corpus callosum helps to connect the right side of the brain to the left side of the brain, so everybody's talking to each other and nice to each other. Really, nobody ever has a stroke in the corpus callosum. It's pretty rare. We can get white matter disease there, right? We can get demyelinating issues there. So people with MS will sometimes have lesions there, and that's why the right and left side of the body might not be talking to each other very well. But the vermis connects the two hemispheres of the cerebellum. So you have somebody who has a stroke in the vermis, the two sides of the cerebellum, which are supposed to play nice to each other and are supposed to help maintain your position within space, are not talking to each other. They kind of got divorced, okay? So that area is, even though it's small on real estate, it's like downtown Manhattan, okay? Location, location, location. So again, when we talk about the corticobulbar tracts, we'll kind of jump here. Remember, those are just essentially, think of those really as just the cranial nerves. And we'll talk more about the cranial nerves today. When we talk about the corticospinal tracts, so these help to mitigate all of our voluntary movement, okay? So you're walking, you're not so much, a little bit of your talking, because they help control your voice box and all that kind of good stuff. Integrated skills, complicated stuff, all your delicate, fine motor movements, writing, tying your shoes, brushing your teeth, all the stuff I hope we did today. They also help to inhibit some motor tone, so they help you know what not to do, or if there's one side of the body that's moving, it will control the other side of the body from moving, okay? Just again, so we have that fluid motion. They originate in the motor cortex, but again, and then they drop down the lower medulla, and this is basically where they cross. And again, ballpark it, about 80-85% of them cross. Okay, I'm never going to ask you an exact percentage. But they cross over and they synapse and they head down. And that is why we get that right side of the brain controlling the left side of the body and left side of the brain controlling the right side of the body, because the majority of those fibers cross over. We talk about the extrapyramidal system. So again, here we're talking primarily basal ganglia. So we mitigate voluntary body movements, postural changes, autonomic functions happen here. Especially fine motor movements in the extremities, we kind of help to refine that motor function down even further. Basal ganglia, so again, caudate nuclei, lenticular nuclei, plus or minus on the amygdala. So the amygdala helps to control basically some of your memory is there, some of your emotion. You know, some people think that their amygdala maybe took a vacation sometimes. But plus or minus as to whether that's actually included in the basal ganglia. Again, it's kind of like the substantia nigra. It depends on who you read. We should all probably go back to Menor, right? He's probably the god of anatomy. When we talk about the basal ganglia system, and again, this diagram just really highlights exactly what's in the basal ganglia versus what's in the diencephalon. And remember, your diencephalon is really just your thalamus and your hypothalamus. So it's really your relay station for your sensory input, but it's also that motherboard to the motherboard, right? So it is the control aspect to your pituitary gland. And we talk a lot about the pituitary gland just because it controls all the fun stuff, right? So it controls our thyroid, which is always good, you know, but it also controls like luteinizing hormone, follicle stimulating hormone, testosterone, estrogen, prolactin, you know, all the stuff that's really important. That's where it all comes from, the pituitary. So in the basal ganglia, so we have motor pathways. So we're between the cerebral cortex, basal ganglia, brainstem, and spinal cord. So again, everything's helping to refine that motor function down to get what you want to do into what you actually, I can't believe I'm going to say this early in the morning, do, okay? It's Wednesday. So it helps to maintain that motor function, especially like gross automatic functions that we do all the time, walking. You don't really think, I gotta put my left foot down and my right foot down. I mean, that would be horrible, right?
Sometimes.
What'd you do last night? Depends on which cop pulls you over. No, I'm kidding. That's poor form. Okay, so we talk about the cerebellum. So again, we're located now in the posterior fossa. We're truly below the tentorium, so we're essentially out of the cerebral cortex. We're lower. We're a little bit more protected. Okay, still obviously in the skull, and the skull is a good thing. Again, we had that small midline vermis. Again, it's very small, but it's like downtown Manhattan. Very, very important because it really helps to regulate what the left side of the cerebellum is saying to the right side of the cerebellum. Really helps to help coordinate those motor functions. And then we have the two large hemispheres. So basically, orientation kind of halts or checks our motion. So maybe halts or protects you from picking up the third beer or the sixth. Fine motor movements of your hands. Believe it or not, the vermis can help. If you have a stroke in the vermis, it actually helps, hinders in terms of even speech production, because it can cause a fasciculation with the palate to where they can't even speak normally because their palate is moving like 400 and 500 times a minute, okay, rather than being stationary. So this part, it helps to really refine all forms of fine movement, even our speech. So when we look at in terms of cerebellar involvement, in terms of clinical exam, we look at balance, we look at coordination. So this literally is the drunk driving test, okay? Put one foot in front of the other, you know. You have some older patients, they cannot do that because if they haven't had even a stroke there, they may just have had cerebellar atrophy that's kind of disproportionate to their age. So you may have them doing all sorts of this, you know, and they haven't been drinking at 10 o'clock in the morning. Some of them have, but not all of them. But truly, if they get cerebellar atrophy, it can essentially mimic the clinical presentation of a stroke because they don't have that fine coordination present. We talk about gait, we talk about accuracy of movement. So whenever we do finger to nose, that helps with our coordination as well. So all of those, finger to nose, the walking, standing on one leg, the ability to actually stand like a flamingo, is helping to be controlled by your cerebellum. Again, when we talk about the thalamus, so again, these are parts of the nuclear structures, deep nuclear structures. They are on either side of the third ventricle as we look anatomically. And again, this is just essentially more of the ventricular system. So you can see the lateral ventricle transitioning to the third and then going down to the fourth ventricle before it exits out into the spinal cord and kind of recirculates that CSF. Anybody know how much CSF we produce every day?
150.
Very good, 500 cc's.
Oh, 500.
Anybody know how much we actually net? How much we actually have at any one given time?
150.
150. Good answer. Oh, you guys are good. There we go. Fantastic, right? So we turn it over all the time, which is why people who lose CSF, you don't really have to worry about them too much. You lay them flat, they'll reproduce more CSF. So chief in terms of sensory and motor integration, basically all of our sensory input, I know I've kind of beaten the thalamus to death. Emotional aspects of sensory input, so kind of that you can recognize that it's hot and pull away very quickly, those types of things are relayed also through the thalamus. Again, our alertness, our attention span, our level of consciousness is somewhat regulated in our thalamus as well. Our pain perception as well as our thermal sense. So again, I probably shouldn't keep my hand on this hot stove that's turned on the burner because it's really, really hot. You know, it's that initial impulse to go ahead and pull away. So again, really just looking at where it lies. So here's your lateral ventricle. If we're going to do a sagittal image and just look at one hemisphere, here's your lateral ventricle. Thalamus is sitting right to the lateral aspect of that. Hypothalamus, again, it's located below the thalamus. It says it really includes the optic chiasm. It really doesn't include the optic chiasm. The optic chiasm sits just inferior to it. It does have a relay station, though. Think of it almost kind of like almost like a watershed type of function from the hypothalamus down to the pituitary. And remember, what overlies the pituitary gland is the optic chiasm. Okay, so you're transitioning right through that segment to transmit the appropriate stimulating hormones to the pituitary gland. Okay, and the problem is if you have an issue with the pituitary gland or you have an issue with the hypothalamus, you're gonna get the optic chiasm involved. Okay, and essentially that's right where our optic nerves help to half of them cross. So it's responsible for all of our temperature regulation. Again, all those good hormones, growth hormone. Anybody see that thing on TLC about the woman in China who's like 7 feet tall? Yeah, she might have a pituitary tumor, you think? Okay, she keeps growing. Those people that have like frontal bossing, their frontal part of their skull is huge and it just continues to grow. So the frontal bone will grow in those patients with growth hormone issues. Their glove size, if we lived up north, would change. Their shoe size would change. And this isn't just somebody who gained 80 pounds with a pregnancy and their shoe size went up a half. Okay, this is somebody who I used to wear a 7 and now I wear a 9. That's a problem. Okay, it controls all of our follicle stimulating hormones, so it allows us to actually produce eggs, to produce sperm, luteinizing hormone, prolactin. Both men and women have prolactin. Women have more, so that's what allows us to actually nurse after we've delivered a child. So it stimulates milk production. All of those important hormones that are basically directly produced by the pituitary gland have to have stimulation from the hypothalamus. And so that's when you look at even endocrinological issues, kind of where's the source? You know, is it thyroid or is it pituitary or is it hypothalamus? You might have a couple different areas if you're truly even just looking at a thyroid issue, okay? Thirst, appetite, water balance, all that kind of stuff is regulated by the hypothalamus as well. So we talk about the brainstem. Brainstem basically has 3 components. How am I doing? Okay, not bad. Brainstem actually has 3 components. Oh, hey, I gotta talk faster. Okay, the midbrain, the pons, and the medulla. Basically, they are the relay stations between essentially the upper aspect of the central nervous system, so essentially all your cerebral cortices, as well as your cerebellum, and the peripheral nervous system, right? You gotta have a way to get to the spinal cord and then get to the peripheral nerves. And your brainstem is how you do that. It's the origination of cranial nerves 3 through 12, although 2 comes right past it, and we'll talk about that as well. It has the reticular formation, so that basically comes right up through it to help relay to the thalamus. Basically, your reticular formation is your control of consciousness, whether you're awake or not, whether you're aroused or not. All that stimulation will come through that system as well. So I put a little cheat sheet over here. I texted my boss last week when I pulled. We used to always write cheat sheet notes for each other about stuff. So this was his handwriting. So always remember that at the level of the midbrain, you have 2, 3, and 4. Okay. At the level of the pons, you have 5, 6, 7, and 8. And at the level of the medulla, you have 9, 10, 11, and 12. And that's basically where they come out. And this is if we're going to kind of flip the brain upside down and look at the undersurface. And it helps in terms of if there's a tumor, if you have a mass, if you've had an injury, where did the nerve originate and why is that a problem? And what other nerves might be affected? Certainly if you had, for example, trigeminal neuralgia, okay, which is involved with trigeminal nerves, so cranial nerve 5, is it adjacent? It's obviously adjacent to cranial nerve 6. So now we're starting to look a little bit more so at their eye function in terms of motor movement, because cranial nerve 6 helps to control one of the motor directions of our eye, right? Lateral rectus. So you start to look for other things based on what your primary neurological concern is. So we talk about the midbrain. So we have the superior and the inferior colliculi. Those are always fun words to say, right? We have the cerebellar peduncles. So these are the motor nuclei of both the trochlear nerve as well as the ocular motor nerve. Okay, so that's where that actual motor cortex originates. And that's why cranial nerve 2 kind of comes actually more so from your occipital cortex, but it's going to pass right above. Superior colliculi is going to be association of your visual system. So again, that's where you help to kind of understand what you're relaying back to your occipital and your visual cortex in terms of what I'm looking at as a tree, what I'm looking at as a stoplight, that type of thing. Those things that are learned over time. And your inferior colliculi is going to be associated with your auditory system. So it's going to help relay kind of input sense. So even though your auditory system is really located and kind of housed in your temporal lobe, there's other aspects that are located within your midbrain as well. We talk about the pons. So the pons sits both ventral to the cerebellum as well as rostral to the medulla, just in terms of location. Again, it's going to contain the motor and sensory branch of the trigeminal nerve. Remembering that the trigeminal nerve has 3 distributions that we'll go through, but it is a fat nerve. I mean, you want to talk about obese. Let's talk about the trigeminal nerve. It's big, both anatomically and in terms of what it does. Okay. Then we talk about the abducens. We talk about the facial and acoustic. They all exit through the grooves that divide the pons from the medulla. Okay. Your corticospinal tracts, they haven't crossed yet at this level, right? They're going to cross right below. And again, we're going to cross about 80 to 85% of those tracts are going to cross there. Knowing that everything that you see on clinical exam the reason why I keep saying it isn't because you're going to be tested on it. It's only because I want you to understand that not everything crosses. So clinically, it may not always fit the right picture, but at least kind of gets you in the right direction, okay? So when we talk about the medulla, so this is between the pons and the spinal cord, God bless you. So again, this is going to be hypoglossal, this is going to be vagus, glossopharyngeal, spinal accessory is going to be crossing here, and this is where we actually have the crossing of those corticospinal tracts that are going to cross as they head down the spinal cord itself. This is my favorite part. I only made it one slide though. So the circulation to the brain, so we have two internal carotid arteries that come up the front of the head. Plus or minus on kind of what literature you look at in terms of how much circulation they carry to the brain. Some say 80%. It's probably more like 2/3 or 70%. You know, it's probably not quite 80. They're big. Always remember that the internal carotid arteries in boys are bigger than the internal carotid in girls. Just like everything, you know, most arteries are bigger because most boys are bigger, type of thing. Okay. Just a side note, when they actually say that like a man is thick-skulled, it's not the case. Women actually have a thicker skull than men do. Just so you know. So when we talk about the internal carotid arteries coming up, so the internal carotid arteries come north, right? They are a bifurcation off the common carotid, and they further bifurcate, right? So they further take a fork in the road, and they make the middle cerebral artery and the anterior cerebral artery. So we look at the middle cerebral artery coming laterally. That's basically what goes to feed the ha of how, right? H and A are fed by the middle cerebral artery. And if you look anatomically, so you can't really see the internal, well, here's kind of the internal here. It kind of is a straighter shot, so to speak, to go to the middle cerebral artery. And that's why 85% of all strokes are MCA distribution. That's why the majority of people that you see have a weak face and a weak arm. It's not because, you know, it's truly anatomical. Think of the middle cerebral artery as being like the easy takeoff off of 75. Whereas the anterior cerebral artery, which is going to go medially and is going to feed the L of how, is more of like the cop that has to pull the UE to turn around and catch you because you're speeding too fast on the other side. Okay, so it is almost like a 90-degree turn, if not a 110-degree turn. That's why most strokes don't happen there. When we go posterior circulation, we have two vertebral arteries. They join to form the basilar artery, and that bifurcates to form essentially the posterior cerebral arteries, but they also arise and give you the posterior communicating artery. Okay, so think of your vertebral arteries essentially as like, or your posterior circulation system is like a body. Your legs are your verts, your body in the center is your basilar artery, and then you've got your arms, which are essentially your posterior cerebral arteries, which give rise to the posterior communicating arteries. So this is lovely, the lovely circle of Willis that we always talk about, right? Everything's supposed to talk to each other. We're supposed to have posterior communicating arteries that help to contribute from the posterior circulation to the anterior circulation. We're also supposed to have an anterior communicating artery that communicates the right side to the left side between the anterior cerebral arteries up here. Only about 30% of us come out of the factory this way, right? Only about 30% of us are born with everything intact. It's fantastic by design, right? But the majority of us have an anomaly somewhere. An artery that didn't really develop as much, an artery that didn't develop at all. Some people only have one vertebral artery. Some people only have one posterior communicating artery. Some people don't have an anterior cerebral artery. You really don't know that until angiographically you would need to do a study, or they have a stroke and you're wondering, well, how the heck did that happen? They should have had collateral circulation there. So remember, the majority of us don't have collateral circulation. And basically, if you weren't born with it or you didn't form it about in the first 2 years of your life, done deal, okay? You're not forming it when you're 80. You're not even forming it when you're our age, okay? It just doesn't happen. All right, so moving right along. When we talk about the spinal cord, this is a cylindrical mass. Really, the length of it is determined by your height, okay? So those of us that are taller have one that's longer. And those of us that are vertically challenged have one that are shorter, okay? But basically, the distal end is attached to the coccyx, and there we have the filum terminale. So basically, you have this tiny little cord that radiographically is usually very hard to see, even on the best MRI, but it's going to attach all the way down to the end of the coccyx. We basically have two halves, so we have an anterior medial fissure and a posterior medial sulcus. We have both gray and white matter, just like we have in the brain. We have gray and white matter in the spinal cord, and that becomes important because when we talk about various strokes or we talk about myelinating issues and we have white matter changes in the brain, probably going to have white matter changes in the spinal cord, right? It's not going to happen in the gray matter because it's going to involve that myelin. So your gray matter is the center, and it's a butterfly. It's nice and pretty. It has the anterior portion, which is essentially your motor portion. When we talk T1 to L2, and L2 is kind of loose, okay? Because the majority of people, their spinal cord, their conus actually occurs about L1, 2. So it's really wherever your conus occurs. Some people, the end of their spinal cord, their conus medullaris, is at T11, T12. Some people it's lower. Some people it's L3, 4, okay? Shouldn't be L3, 4. It should be L1, 2, T12, L1. So it's wherever essentially the conus medullaris is where you have the end of your lateral horn. And your lateral horns are those autonomic motor functions. Whereas our posterior horn is that receptor portion, right? So that's our input that's going to go all the way up to the thalamus and then go to the somatosensory cortex so that we can then transmit down our motor function. So the white matter, it's going to links the spinal cord segment and it connects it up to the brain. So we have those three columns. We have the anterior or the white ventral column. So those are those descending fibers. Okay, so the descending fibers, voluntary movements, light touch sensation, that kind of thing will occur there. We talk about the lateral white column. So those are, again, more of your voluntary movement, but again, your pain and your temperature Sensations are going to be there as well. And when we talk about the posterior, then we're talking more about joint sense, passive movement, position sense, that kind of stuff is going to occur there. And this next slide has kind of a good picture with lots of pretty colors that basically shows you all of where the tracks are lying. And you can imagine essentially what is occurring in terms of your anterior spinothalamic, kind of puts it right there, touch and pressure, lateral spinothalamic pain and thermal sense. So when we talk about the spinal cord itself, we have 31 pairs, right? Because we've got 8 that occur within the cervical spine. Remember that C1 actually exits, that cranial nerve exits above C1. So at the junction of C7, T1, you actually have the C8 nerve root exiting. And then after that, at T1, T2, you have T1 nerve root exiting. Okay, so remember you have 8 within the cervical spine, we have 12 within the thoracic, we have 5 within the lumbar, 5 sacral, and 1 coccygeal. And remember, sometimes people have a 6th lumbar vertebra. So some of your taller patients will actually have a 6th lumbar vertebra. It's just an anomaly. It doesn't necessarily mean that they have a different nerve. What they may actually have exiting there is one of their sacral nerves. Okay. Sometimes that what looks like a 6th lumbar vertebral body is actually just a non-sacralized S1, meaning that it kind of never joined with the rest of the sacrum. Okay, so it's another fixation. It's another, I shouldn't say fixation, another moving segment that should have potentially been fixated long term. So when we talk about afferent fibers, so those things coming in versus our efferent fibers, those things going out and producing that motor function. Remember when we get down to the basics and we just talk about even the knee reflex, whoopsie-daisy. We have to have an intact sensory limb. You have to have that intact synapse within the spinal cord. You have to have an intact motor limb, and you actually have to have a limb, okay? So you actually have to have intact muscle function for that nerve to innervate. If any one of those things are missing, you will not have a knee reflex, or you will not have a plantar reflex, or you won't have a, brachialis reflex, okay? So you have to have all 4 segments to get to the end result. So just because somebody doesn't have a reflex doesn't necessarily mean that they have a spinal cord injury, right? They may be lacking one of those 4 components that go into actually giving you that result on clinical exam. So again, this just kind of like gives you more of a schematic. You got to have the right input. It's just like a TV, right? You have to have the cord coming into the house. You actually have to plug the cord into the wall. The TV's got to be working, and the show's got to be on. Otherwise, you're not watching news. Okay, all 4 things have to be working and functional. So motor pathways. Let's maybe take a break. Okay, right?